Okay, we're going to look through reproductive physiology today, hopefully going a bit more systematically than you've been taught, because I know they kind of just scatter everything everywhere. But I find it a lot easier to just think it through female and male, and then all like the baby making processes like fertilization, placenta stuff, and then birth, which is a bit different. I think we categorized menopause as a pathology, so we're not covering that. We'll do that tomorrow. Okay.
Controversial take, but we did it.
It's very controversial. I think it's quite obvious it's issues. So we'll start with the ovarian menstrual cycle. They're obviously very tightly interlinked. When they say the ovarian cycle, they're talking about the cycle here. So with the egg and the follicle. And I think it's very important to separate the egg or the ovum from the follicle, and then like the corpus luteum, which are just the cells that support the egg itself. And then the menstrual cycle, obviously everything's interlinked, but that's just the endometrium, and that's about like having your period, and then the lining of the uterus building up over time again. So this is the grand overview. I think if you have like a good grasp of this, everything else will make a lot more sense. So we'll go through this really carefully. So at the start, or in the first half of the 28-day cycle, we have a follicle surrounding the egg that is slowly growing. And the follicle is made up of these cells called granulosa cells. And we get into that a bit more later. But what these granulosa cells do is they produce estrogen. And so when they produce estrogen, you're going to see an increase in estradiol, another name for estrogen. And the effect of that is that works on your endometrium. So we'll ignore the period part for now, but what it essentially does is it causes the proliferative phase of the menstrual cycle, where you can see that the lining actually just builds up over time. Now, at low concentrations like this, estrogen has a negative feedback on FSH and LH, so follicle stimulating hormone and luteinizing hormone, which are released by the anterior pituitary, which is a part of your brain. So this will go back up and inhibit FSH and LH. So you can see that that's why the FSH and LH are relatively low in the first half of the cycle. But as estrogen rises at high concentrations, it actually has a positive feedback effect on FSH and LH. And so it'll go back up to the anterior pituitary and tell it to secrete more FSH and LH. And because of that, you get an increase in both of them, especially the LH. So we call that the LH surge. It occurs just before, you can see the midpoint here at day 14. And the LH surge is really important, and it's really important that it comes just before day 14 because it causes ovulation. You can see the ovulation at the ovarian cycle here. And then because the egg has been released, it's like doing its dandy thing, traveling along fallopian tube. It's no longer in the ovaries. And the leftover cells that was forming the follicle becomes the corpus luteum. And the corpus luteum is no longer made up of granulosa cells, it's made up of lutein cells. And lutein cells are different because they release progesterone and estrogen. And so you can see, because you have the corpus luteum there, you now have an increase in your progesterone in the orange and the estradiol in the blue. And that's why you get your peak around day 21, day 20-ish of these two hormones. And these two hormones working together will cause the secretory phase of your menstrual cycle, which we'll talk about a bit later as well. And then if pregnancy doesn't occur, if fertilization doesn't occur, then you have degeneration of the corpus luteum. It stops secreting these two hormones. And because you stop secreting these two hormones, there's no endometrial support anymore, causing menstruation day 0 to 4 or 5. And also there's no more inhibition on FSH and LH, so the follicle can grow again. I hope that makes sense. If we've got any questions, just pop them in the chat. But it's quite repetitive, so hopefully by the end of it, you'll have a good idea.
I just want to rehash that, like, that graph on the slide before is like basically like your holy grail. So if you like know it well, most, if not all of like the rest of this stuff will make sense. So just like know what's going on with these spikes, know what the spikes do. And that will help a lot.
Yeah, and I think knowing kind of the order and knowing why one thing leads to another is really helpful. This is another picture just for visual learners like me. So the ovarian cycle. So we'll go through this a little bit again in a little bit more detail. It's specifically the changes in the ovary during which the follicle over here matures, the ovum is shed during ovulation, and the corpus luteum develops. You have the follicular phase in day 1 to 14, which is the first half, easy to remember, and that's also because you have the follicle, so easy to remember again. And then you have the luteal phase because of the corpus luteum in the last or in the second half of the cycle. So folliculogenesis is this process where you go from like a mini baby follicle to like a big mature big boy follicle. It takes more than 6 months for this whole thing to happen, and you have a lot of eggs, and all females are born with all the eggs, right? So essentially you have a lot of these early antral and pre-antral, which is kind of like here, follicles in the ovaries between puberty and menopause, which are ready to just kind of go at it at any time. So you start off with your primordial follicle. The most important thing to remember about this is it's a single layer of squamous stromal cells. Now, stromal is like a type of connective tissue, and because your follicle is not the egg, it's just supporting the egg, right? It's just supportive tissue. That's why I guess that you can kind of remember it like that. Stromal is connective tissue and just like supporting the egg. Squamous means that it's flat. So essentially just think at the start, it's a single layer of like these flat cells around the oocyte. That's present before birth, and then each month between puberty and menopause, some are recruited and activated. And that causes formation of your primary follicle. And these are now cuboidal granulosa cells. So remember from this slide, I said the follicle is made up of granulosa cells. So yeah, that's basically what's happening here. Gone from these squamous cells to cuboidal, so square granulosa cells. You can remember it's squamous to cuboidal because it's literally just growing. I guess flat cells are smaller than cubed cells. And you also have formation of the Zona pellucida just underneath there in the white. I don't know if you can see, but that basically serves as a layer of protection, which we'll go through later. And then you enter your pre-antral follicle, which they sometimes also call the secondary follicle. And by this time, these cells have divided, and so they proliferate to form stratified epithelium. Stratified just means there are lots of layers. And then the connective tissue outside of your granulosa cells form thicker cells. And these function with the granulosa cells to produce estrogen. So LH will actually work on the thicker cells, and that produces androgens. And then FSH will act on the granulosa cells, which will convert the androgens to estrogen via aromatase. So you need both of these hormones and both of these cells to make estrogen. And then you reach the early antral follicle. These, it's literally in the name, have small antrums. So they have their little fluid-filled spaces. And then the follicular cells by the oocyte form the cumulus oophorus. And then at the start of each menstrual cycle, there'll be about 10 or 25 preantral and early antral follicles that develop into larger antral follicles, but only one dominant follicle will continue to develop. And that's dependent on the local estrogen within the follicle. And that just means you're not releasing 10 to 25 eggs every single cycle. And then you reach the antral follicle, again in the name, because it's not early anymore, they've kind of fused to draw in one single antrum like this. And then lastly, you have your mature or Graafian or tertiary or pre-ovulatory follicle. There are like a million names for it, so I thought I'd put them all down to avoid confusion. And by this time, remember, all of this whole folliculogenesis thing has to do with the follicle and not the oocyte. But I thought I'd just mention here that by this stage, that's when the primary oocyte completes its first mitotic division into the second oocyte. And then the cumulus oophorus, which is like this bit, separates and floats in the antral fluid, which is connected by the corona radiata, like that. And then you reach day 14, ovulation, again due to our LH surge, like I mentioned before. Essentially, it just bursts out of the ovaries into the peritoneal cavity. It's like whipped up by fallopian tubes, and they travel down towards the uterus. And then the remaining follicle becomes your corpus luteum. So these are made up of luteal and thecal cells. They form like a fibrous clot. And they secrete progesterone and estrogen for about 3 months if pregnancy occurs. And if no pregnancy occurs, it degenerates about like within 10 days and becomes the corpus albicans, which is just a mass of fibrous tissue. Right here. So this is the hormonal control of the follicular and the ovarian and the menstrual cycle. I think the main take home from here is you can see that up the top you have these GnRH, gonadotropin releasing hormone pulses. So you can see that it's actually due to the frequency of pulses, and GnRH is released by the hypothalamus, and that's what's regulating the entire day. I've summarized like kind of when they rise and fall over here. I'm sure you can take a look in your own time. But yeah, just remember that LH and FSH rising near the center to cause ovulation, progesterone and estrogen rising in the second half for your secretory menstrual phase, and then estrogen rising at the first bit as well because it's secreted by follicular cells. Okay, we'll go through the hormones again, apparently. So follicular phase, you have your GnRH released by the hypothalamus up here. That's another part of your brain. And that causes release of FSH and LH by the anterior pituitary. And it's important to remember that it's the anterior pituitary because the posterior pituitary secretes something else. I'll come to that later. The LH works on the thicker cells, as I mentioned before, to produce androgens, and then the FSH works on the granulosa cells, which will use aromatase to convert the androgens into estrogens. So you get an estrogen increase in the early and mid-follicular phases, and that causes certain changes. It causes, great here. And then estrogens will work back on these guys to have negative feedback and decrease their concentration at low doses, and only the dominant follicle survives a drop in FSH. And then as the follicle matures, you have more and more estrogen, which ends up having a positive feedback effect on your hypothalamic pituitary axis. Hence, you get an increase in your LH, and that causes ovulation. Yeah, that is a summary. You don't have to know all that. I thought I just put it in. And then you enter your luteal phase because its ovulation has happened. You have your corpus luteum. You have more secretion of progesterone and estrogen secreted by the corpus luteum, which negatively feedbacks to LH and FSH. And it also releases inhibin, which decreases FSH. And declining levels prevent development of additional follicles and prevents additional LH surges, which would cause more ovulations. And then the corpus luteum degrades within 2 weeks. This is another summary for people who want to look at this. This is a summary of some of the ovarian hormones and their functions. So estrogen at low concentrations inhibits FSH and LH. At high concentrations, causes the LH surge. produced by the follicle via LH and FSH and the corpus luteum. It thins the cervical mucus. It causes the proliferative phase of the menstrual cycle and promotes progesterone receptor expression. We'll come through with some of that again later. Progesterone is produced by the corpus luteum. It thickens the cervical mucus. It inhibits prostaglandin. So there's no contraction and there's low fallopian tube motility. Again, we'll cover that a bit later. And then the anti-Müllerian hormone, which also indicates the follicular number, ovarian reserve, decreases with age and infertility. And we'll come across this again during sex determination. Great. So we've covered the ovarian and the follicular cycle now, and we'll go through the uterine and menstrual cycle. So this is what's actually happening in the uterus with regards to having a thicker wall or shedding it, etc. You have 3 phases this time. So days 1 to 5, menstruation, they've totally averaged that. Of course, women can have shorter or longer periods. And then you enter your proliferative phase because you've shed everything, you need to build it back up. And then at day 14, 15, again, it switches to the second half of the cycle, which they call the secretory phase. It's good to know a little bit of anatomy here. So it's the endometrium, which is like the most inner part, so the most close to the lumen of the uterus, is made up of 2 layers. One is the stratum functionalis, one is the stratum basalis. And essentially, the most important take home from here is that the stratum functionalis is the bit that functions. It's the bit that like comes off, grows again, and goes through the menstrual cycle. The stratum basalis is not responsive to your ovarian hormones, and it remains there. You have a couple cell types in there. It's good to know about the spiral arteries because they come in a bit later. Well, I'll tell you them probably on the next slide. But yeah, you have a columnar epithelium. You have connective tissue stroma, like I mentioned before. And you have some uterine glands right here, this yellow thing. And stratum basalis has all the same cell types, but it's just a bit more compact. So the menstrual phase. Essentially, it's triggered by the decrease in estrogen and progesterone. Remember, that's because of degeneration of our corpus luteum and deprivation of the endometrium of that hormonal support. You have an increase in prostaglandins, which are produced by the endometrium itself in response to a decrease in that estrogen, and that causes vasoconstriction of the spiral arteries, as well as uterine contractions. And because you've got vasoconstriction of the arteries, basically it's cut off the supply and it causes ischemia, so cell death. So the endometrial cells in the functionalis die because they're deprived of oxygen and nutrients, and then the spiral arteriole dilate, and that causes bleeding. So hemorrhaging means bleeding through the weakened capillary walls, and that causes, that in conjunction with the uterine contractions, causes the stratum functionalis to kind of just fall off, and that's why you get your period. Yeah. And then you enter your proliferative or pre-ovulatory phase, days 6 to 14, where you have rebuilding of your stratum functionalis. You have all these things like proliferation of your glandular epithelial cells, your stroma, and your blood vessels with enlargement of glands. That's due to an increase in plasma estrogen, remember, due to our follicle development, and that promotes progesterone receptor expression on the endometrial cells and thins the cervical mucus, allowing the passage of sperm into the uterus for ovulation. On histology, this is like quite high yield, so having these long, straight glands with nothing in them. So you can see they're long and straight, but you can't, they're quite thin, right, because there's nothing in them. That's basically all you have to know for that bit. The secretory or post-ovulatory phase, day 15 to the end, 28, prepares the endometrium for implantation. So you have the glands and stroma enlarging even more, you have arteries elongating, you have secretion of like a lot of glycogen, polysaccharides, etc. So they're really trying to nourish the uterus. And that's driven by progesterone and estrogen, because that's what's secreted by corpus luteum. And this rapid increase in progesterone, and remember before we had a promotion of progesterone receptor expression, so now we have even more effect of the progesterone, causes cervical mucus thickening, so no more sperm comes in, and it also protects the embryo if fertilization has occurred, and it inhibits prostaglandin-induced contractions of the myometrium over here, which caused menstruation earlier. If fertilization doesn't occur, corpus luteum degenerates, there's no more progesterone, and then that causes spasm of arteries, low oxygen levels, and then menses again. On histology, they have a classical like sawtooth and coiled glands. So you can see compared to here, which was super straight and nothing in them, these are now like wiggly as, and they have stuff in them. So it's got white spaces because of all the secretory products. You can also see that this is like thick. So like it's twice as thick. So if you compare that to that, it's quite obvious. Alrighty, that's all of female physiology. Any questions so far? Nope, we'll move on. Okay, so function of the testes. They have two main functions. One is androgen, which is testosterone production, and one is spermatogenesis, so the making of sperm. And there's a little bit of hormonal control involved. So again, it's your hypothalamus secreting your GnRH, and then that releases, well, that goes to your anterior pituitary, which then secretes FSH and LH. And FSH and LH, kind of like in the ovaries, which do separate things to make estrogen, do separate things in the testes as well. So these go into your blood, it's released into your blood via anterior pituitary, reaches your testes via the bloodstream. And then the way I remember this is if SH works on the Sertoli cells to cause spermatogenesis. So SSS, easy to remember. The one caveat is you need testosterone for that to occur. And then basically, and also the Sertoli cells will also secrete inhibin, which goes back to inhibit FSH. LH, again, easy-ish to remember, is LH and then Leydig cells, so L and L. And because it's not spermatogenesis, it's making testosterone, which allows for spermatogenesis to occur by the Sertoli cells, and also goes on to do other things in the body. And we'll explore that a bit later. One thing to note is TSH, LH, FSH, and HCG, beta HCG are structurally similar, so they have similar effects, and we'll see how this affects certain ways we can treat things and certain management options for pathologies tomorrow. Diseases are also characterized by primary and secondary testicular failure. So when they're primary, they occur at the testes. So it's something wrong with your Sertoli cells, Leydig cells, etc. And so you have an increase. If there's like a decrease in testosterone or inhibin, there's actually an increase in FSH because your anterior pituitary is like, what's wrong? Why is nothing being secreted? Let's just send more signals. So hopefully they'll listen and secrete more stuff. Secondary diseases are at your anterior pituitary. You literally just move one up and you see all hormones decrease because you have less FSH and LH, and that causes like fewer signals towards your Sertoli and Leydig cells, which in turn secrete less inhibin and testosterone. Okay. Androgen production. So like I said, produced by your Leydig cells in response to LH, and it leads to spermatogenesis and male puberty and virilization. Virilization just means like the development of male characteristics. And it works via these ways. I was kind of confused when we had to learn it, but actually it's just literally telling you how testosterone is going to work. So it can work directly, and that targets your muscle, and it also causes the development of male characteristics. It can also work so it can be converted via 5-alpha reductase into DHT, and then because they're DHT, they can target other things. So they can target the prostate, the skin, by an androgen receptor, and that causes pubic hair and sebum secretion. And they call that whole pathway the amplification pathway. And then it can be converted into estrogen via aromatase, and that can target the brain and the bone. So that causes bone maturation and epiphyseal closure. And they call that whole pathway the diversification pathway. And then it can be inactivated. So it's inactivated via your liver through oxidation and conjugation and renal excretion. Remember, there's no male menopause. Serum testosterone falls 30% between the years of 30 to 70, but that's largely due to obesity and chronic disease. It shouldn't really happen if you're just like a happy chap, healthy individual. Male puberty, so the onset is triggered by pulsatile GnRH released from the hypothalamus, which causes a rising LH, causing the Leydig cells to secrete more testosterone, and hence, sorry. Okay, it causes the, I'm gonna turn okay, yeah, and then testosterone forms metabolites, like I said before, by estrogen or DHT, dihydrotestosterone, to work on the bone or the hair and acne. You have Tanner staging. You don't have to know this exactly, just know it exists. And then for testicular volume, again, I wouldn't really say these exact measurements are important, but you should know that it's assessed with the orchidometer, which is this guy right here. Asymmetry is common, and reduced testicular volume parallels with reduced spermatogenesis. So it's actually directly correlated. Spermatogenesis, it's such a long word. Okay, production of sperm, you have about 100 million per day. Ejaculate normally contains around 2 mils with 40 million sperm, so that's a lot. And it relies on high levels of testosterone from our Leydig cells and the LH and FSH that act on Sertoli cells. And remember, it's the FSH acting on Sertoli cells and not the actual germ cells that allows for this whole process to kind of happen. It's pretty self-explanatory, in my opinion. You go from your spermatogonium by mitosis, still 2N because it's mitosis, to your primary spermatocyte, undergoes meiosis 1 to essentially the chromosomes are split, right? So you only have 1N, where you have in your secondary spermatocyte undergoes meiosis again to form your spermatids, and then via spermiogenesis that forms the spermatozoa, or for short sperm. One thing to note is they haven't shown it on here, but male germ cells don't complete cytokinesis. So the whole division of like the cytoplasm during mitosis and meiosis. So these guys will actually have little channels connected between them. And that ensures that germ cells are exposed to the same chemical signals from both X and Y chromosomes, even though they only contain either X or Y. And the role of the scrotum is that it holds everything underneath the body, so it's 2 degrees cooler temperature, and they like this buzzword, like a counter-current heat exchange system. So basically it's saying that as cool blood comes up through the pampiniform plexus or the venous plexus, it cools the arterial blood in the spermatic cord entering the testicular artery, and that just prevents a lot of like developmental defects, etc. Spermiogenesis, which is this last step here, turning spermatids into actual sperm, has a couple steps. I think we've covered this last year even, but it involves these guys. Nuclear compaction, so the nucleus becomes smaller. You discard a lot of the cytoplasm. As you can see, it's not round anymore. You have a tail that develops, and you also have an acrosome, which is quite important. Cross-sections of the testes will show different stages of spermatogenesis in the same seminiferous tubule, because it happens like this. Yeah, I don't know how important this is, but for some reason they drilled it in, so I put it on. this is a histology. I think Gavin already went through most of it with you. I'd say the big thing is just the Sertoli cells are big. And then you have kind of everything near the border here. And then as you become more and more differentiated, you go towards the lumen. So that's the lumen up there. And you can see these little sperm tails up the top.
Yeah, I'd have a vague idea of like what those cells are and like what they look like, just because like you don't need to know what like they are or anything like that. Just know the order of like how they progress, because they give you a histology picture and like what is, I don't know, 3, you need to be able to say, oh, it's a round sperm tit.
Yeah.
And that's really all they're going to do with this kind of thing.
Right.
So just know that.
And the spermatogonium, I think another good thing to know is spermatogonium obviously are always going to be near the border the most, because they're your progenitors, and then like the spermatids will always be closest to the lumen. But yeah, it just goes up. Ejaculation, it's good to know the pathway for this. I think Gavin already went through it. I think I dropped out. But just very quickly, you have your seminiferous tubules where it's all kind of produced. You go into your rete testes, through your efferent tubules, into your epididymis right here. It's where it's stored. Then during ejaculation, it goes through your vas deferens or your ductus deferens via the ejaculatory duct near the urethra, and then it goes through the prostatic urethra, through the actual urethra, out. And it's good to know also the actual composition of ejaculate. So you get 5% from the seminiferous tubules in the testes, which give you the sperm. Epididymis is there for storage. They gain the function of motility and they're able to fertilize an egg. Then you reach the seminal vesicles, which supply 60% via the ejaculatory duct. That contains like alkaline fluid, fructose, prostaglandins, clotting factors. And then the prostate releases prostatic fluid via the prostatic duct, which forms 30%, and that's got citric acid, seminal plasmin, PSA, proteolytic enzymes, zinc, not ink, and then the bulbourethral glands supply 5%, and that's just mucus for lubrication as well as some alkaline fluid. Erection, it's driven by many brain parts. I'm sure you all know what. And then the pathway is like a little bit difficult, but also essentially it's just you've got this cavernous smooth muscle and that relaxes. I wouldn't worry about this stuff too much. And because the muscle's relaxed, that allows inflow of blood into the lacuna space right here. So you can see that muscle has relaxed, allowed blood into the lacuna space. And yeah, so that's due to increased inflow via the dilated cavernosal artery, as well as limited outflow. So blood can get in, but it can't get out. And it can't get out because of elongation of the subtunical vein. And because of that, you get like blood trapped in there. And yeah, that's basically it. Viagra is a PDE5 inhibitor, and PDE5 is phosphodiesterase type 5, which usually removes cyclic GMP to allow smooth muscle to stop relaxing. So you don't get removal of cyclic GMP here, and so you have more cyclic GMP allowing relaxation of the cavernosal smooth muscle, etc., allowing erection to occur. This is the innervation. It's just point and shoot. It's basically it. So PNS for point for erection, and your PNS comes from lower in your spinal cord, S2 to 4, by your pelvic splanchnic nerves. And again, like these letters are great. So PNS for point for pelvic splanchnic nerves. Your SNS for shoot, for ejaculation, comes from your sacral splanchnic nerves, and that comes from T12 to L2. So remember, our sympathetics are always kind of in that sympathetic chain. So it's never going to be down right by S2, S4. And then sensation is via the dorsal penile nerve to S2 to 4. Nice. That's male physiology done. Okay, we're doing good for time. Fertilization. preparing for fertilization. So fertilization is literally fusion of the egg and sperm. It occurs in the ampulla of the oviduct or the fallopian tube. That's really important. You have to know that the fertilization occurs in the ampulla of the oviduct. If you don't know that, then this is a little sad. Get onto it. You need calcium for a lot of the processes for fertilization. And we'll come across that again. And to occur, it requires 2 mature fertile gametes. So the egg has to undergo oocyte maturation. It arrests at metaphase 2 until ovulation. And then after ovulation, the oocyte resumes meiosis 2. And these transitions are controlled by some checkpoints. Sperm has to acquire functionality and maturity in the epididymis, and then undergo this process called capacitation in the female reproductive tract. And they found that it doesn't actually have to be in the tract, but it is time dependent. And after capacitation, sperm are able to fertilize within 1 to 2 hours. So capacitation essentially allows for penetration of the zona pellucida. As we mentioned before, this layer comes in during our primary follicle. And the zona pellucida is on the egg here, just under the, under the granulosa cells. So capacitation allows for 2 things. It causes the sperm tail to become fully functional and mobile, and it allows for the acrosome reaction. So because the sperm tail becomes fully functional and mobile, you have hyperactivated motility, and that increases the force generation, allows the sperm to kind of like penetrate. And then the acrosome reaction is also very important. Like we saw before, the acrosome is this part, this top part of the sperm. So yeah. The actual reaction is an exocytotic effect. So it causes the fusion of the plasma and the acrosomal membranes, and it releases these hydraulic enzymes, hydrolytic enzymes that dissolve the zona pellucida. It's stimulated by literally just binding. You can see it here actually. It binds, it reacts, and that's the acrosome reaction. And it's activated by increase in intracellular calcium. That's only one of the areas where calcium occurs or is used in this whole process. The zona pellucida itself is composed of 3 glycoproteins, ZP123, pretty easy to remember. And that's synthesized by eggs or oocytes as they grow. ZP3 binds acrosome intact sperm. So like that would be working right here. And that causes the acrosome reaction to occur by increasing the intracellular calcium, like here. And then ZP2 binds to the acrosome reacted sperm. Why did they name it the opposite way? Apparently because of the order of discovery. But yeah, ZP3 works first, and then ZP2 works to bind to the acrosome reacted sperm. Awesome. These are some proteins necessary for egg-sperm fusion. Not important as to how they work. They just mentioned it in a lecture, and then it came up in a multi-choice question. So egg protein, CD9, and sperm protein Zona. Just recognize and you'll be fine. Egg activation. So the sperm have been activated via capacitation. The egg should be activated too. That involves 2 major events. Again, you need calcium. And they say that calcium is necessary and sufficient. So that means that if there's no calcium, it doesn't happen. If there is calcium, it will happen. All your mitochondria come from mother, all centromeres from your father. And putting the sperm directly into the egg can cause fertilization. And that's the basis of IVF. So these 2 major events, firstly, cortical granule exocytosis, basically a wave of depolarization. So an electrical current goes through the zona pellucida due to an increase in calcium. And then that causes exocytosis, or like release of cortical granules. And that causes cleavage of your ZP2 and modification of your ZP3. So back to this slide, ZP2 and ZP3 are glycoproteins in the zona pellucida. And because that causes binding of your reacted and non-reacted sperm, that can no longer happen. And so cortical granule exocytosis leads ultimately to a polyspermy block. So no other sperm can enter or attach once your first one has entered. Great. And then resumption of the cell cycle. So sperm head containing DNA inserted into the cytoplasm of the oocyte. You have an increase in intracellular calcium again, which is triggered by PLC zeta. Not too important, I would say. The egg is activated and the cell cycle is resumed. So meiosis 2 happens. You get your ovum and your polar body. And then, yeah, eventually things fuse. You have your microtubules pull the pronuclei together, membranes dissolve, you have your zygote, and then mitosis happens. You start getting the baby. All right. Placentation and early fetal growth. So yeah, fertilization's done. We're gonna make a baby. Pre-implantation. You formed your zygote. Firstly, that's literally just directly after your fertilization has occurred. You can see right here. And then you have like 4 cell stage at around 2 days. By 3 days, you have like a morula, which is 8 to 16 cells. And then by day 8, I think, you have a blastocyst, which is 32 to 64 cells. And that's got your trophoblast on the outside and your embryoblast over here, which is your inner cell mass. Yeah, same thing. By day 12, metabolic needs of the zygote are met by secretions of the oviduct and the endometrium. I don't think this is very important. Yeah, so the blastocyst essentially is just going to attach to receptors on the endometrium, which is facilitated by these integrins on the trophoblast. So this whole process, okay, I say the bold is the important bits. I don't think you have to know all of the details, right? So your trophoblast has integrins, and that allows it to adhere to the endometrium, which has receptors, and then the trophoblast proliferates and becomes your cytotrophoblast and your syncytiotrophoblast. Yeah. And then the decidualization response occurs. This is actually important. I can't say it, but I swear it's important. And that's when your syncytiotrophoblast cells actually invade the endometrial cells. So the cells are actually kind of going into your endometrium until the blastocyst is entirely buried. And then the endometrial cells cover the blastocyst, forming a seal, and the trophoblast initiates some local changes that allows essentially the zygote, all of the blastocyst, to stay in there. The trophoblast cells produce HCG, which signals to the corpus luteum to continue the production of progesterone. And remember that our progesterone decreasing causes menstruation, and you don't want to happen. You don't want that to happen when you want implantation. So that causes the progesterone to continue to be elevated until about 2 or 3 months. Implantation issues. So even with a healthy embryo, the failure rate is really high. More than 2/3 of blastocysts fail to implant, and 1/3 of implanted embryos miscarry. Yeah, so when you don't have HCG, you have a decrease in estrogen and progesterone that causes basically menstruation. And the etiology is largely unknown, but these are some possible things. The placenta. So that's this guy right here. It provides all the nutrients and removes all the fetal waste. So some of the fetal nutrients would be glucose, lipids, minerals, oxygen. Wastes include urea, heat, CO2. And they say that the fetus is independent of the fetal brain, lung, gut, kidneys. So these things aren't developed, and they need to develop before the fetus grows up. But they are dependent on the liver and spleen. So these are things that are already working in the fetus. Yeah. It also serves as a partial immunological barrier, as the fetus is foreign material to the mother. So you don't want the mother's immune system attacking your fetus. And it synthesizes some hormones required for the maintenance of pregnancy and the growth of the fetus, such as steroids, such as prostaglandins, such as HCG, such as all of these usually anterior pituitary type hormones, and relaxin. And then, yeah, so Doppler ultrasound can test the growth of the fetus and function of the placenta. And it's different to a regular ultrasound because a Doppler looks at like your vasculature and the blood flow in these things. This is the placenta. I looked at this at first and I was like, what the heck, last year, but it's actually like a bit more simple than you might expect. Essentially you have, this is like the mom side and this is like the fetal side. So the fetus extends an artery and 2 veins into these things called like chorionic villi, like this. And they're kind of like the villi in your GI system in that they kind of just stick out to increase their surface area and exposure to the outside world where they want to exchange things. And so the outside, this whole bit on the inside, is your maternal blood. And essentially things just work via diffusion, right? And blood is entering that bit via the maternal uterine or spiral arteries, like that. And that's how everything works. So formation. Remember, we've implanted, we have our cytotrophoblast and our syncytiotrophoblasts, and the syncytiotrophoblaст cells have undergone decidualization, and that has allowed the burying of the blastocyst underneath and into the endometrium. So now we're going to form the placenta. Essentially, you have this, for these images, the upper part is like the mum part, or like the uterine vessels part, and you can see the villi here. So that's more kind of towards the fetal side. So you have blood from these uterine spiral arteries, which are called uterine vessels on this picture, and they pool in lacunae, which are just spaces of the syncytiotrophoblasts, which you can see in the blue here. Eventually they merge, and then the cytotrophoblast, which are these cells here, they send cells to anchor the placenta to the endometrium. So this is the endometrium, and the cytotrophoblast is anchoring it to there. And that forms your primary chorionic villi. And then by week 3, your fetal mesoderm cells expand under the cytotrophoblast, and they form secondary chorionic villi. And then eventually blood vessels from the fetus will enter the villi as well to form your tertiary chorionic villi. And so yeah, doing that makes you form this guy. And then eventually cytotrophoblasts will form a cytotrophoblastic shell, where some villi attached to this are called the anchoring villi, like here, and then the villi branching off the side will be called the branching villi. And fetal blood flow is established by week 4. Nice. And then they have another process called conversion. And this is your secondary differentiation of cytotrophoblast cells. And the whole purpose of conversion is to make sure that the maternal blood in this space here, in this space here, in this space here, is at a low pressure. And that's important because there's a lot of blood there, and when the pressure is too high, you have like the villi breaking, you have poor diffusion, and that can cause a whole lot of issues. So how does this occur? Essentially, the cytotrophoblastic cells detach from the villi, and they migrate into the maternal endometrium and the myometrium, and the cells that migrate along the maternal spiral arteries become endovascular extravillous trophoblasts. Seems like long words, but like break it down. So endovascular, inside the arteries, inside the maternal spiral arteries, extravillous because they're not on the villi anymore. So endovascular extravillous trophoblast, and yeah, they'll just work on the spiral arteries. Maternal to embryonic nutrition. So you have histiotropic and hemotrophic nutrition. Histiotropic occurs before implantation or into early implantation. It's just this bit here. They also call it trophoblastic nutrition because it's mainly just endometrial fluids, mainly from your uterine glands, and it passes through to your embryo via diffusion. Hemotrophic is literally just via the placenta, and it works. You can see throughout the rest of the pregnancy. It's complete by week 14. And you can also see that during the entire time, the maternal and fetal circulation is separate because it's separated by the placenta. You have your umbilical artery and vein and your uterine artery and vein. And I remember that like the umbilical artery and vein is between the fetus and the placenta, whereas the uterine is between the placenta and the mother. And then arteries always take things away from the heart, so they're always taking things to the placenta. And also it's important to remember that the umbilical vein is singular, but there are 2 umbilical arteries. Transport is via simple diffusion, facilitated diffusion, and active transport. And you've learned this all in first year, I think, so I won't go over that. And it's also important to know that it's permeable to alcohol, nicotine, and drugs. Hormones. So these are some hormones that are important during pregnancy. HCG, which is produced by the blastocyst. We found 2 to 3 days post-implantation in the maternal urine, and that's the basis of your pregnancy test. Again, this maintains the corpus luteum so that progesterone and estrogen continue to maintain the pregnancy. Progesterone is secreted by the corpus luteum for the first 50 days, and then it's produced by the placental trophoblast. You have this thing called progesterone dominance during pregnancy, and that just means that progesterone is like sky high. I wonder if I have a graph. No, okay. It just kind of rockets up. And there's heaps more of progesterone than of estrogen. And that's because progesterone is involved in a lot of things. It antagonizes estrogens and keeps the myometrium and uterine muscle inactive. So you're not trying to like give birth to a baby that's not ready. It promotes uterine growth with estrogens. It relaxes the smooth muscle of the genital, vascular, urinary, and GI tracts. It's got a lot of things. Essentially, if levels of progesterone fall or if a receptor is blocked, the pregnancy will fail. And that's the basis of medical abortions of gestations less than 7 weeks. Essentially, they give this drug called mifepristone, which is a progesterone receptor blocker, and that causes the pregnancy to fail. Estrogen is secreted by the corpus luteum for the first 6 weeks, and then it's produced by the fetal adrenal and liver in conjunction and with the placenta later. So that's required for uterine growth and blood flow. The fetal adrenal makes a lot. All right, fetal membranes and spaces. You've got a couple layers. You have the chorion, which come from your mesodermal inner cell mass and trophoblast. Then you have your amnion, which has amniotic fluid inside. The amniotic membrane is ectodermal and mesodermal. Then you have your yolk sac, which are endodermal and mesodermal. And then you have your allantoid. Yeah, I'm not sure how to say that word. But essentially that starts at the caudal end of the embryo and grows out. And then it's surrounded by mesoderm to form the allantoid. And that fuses with your chorionic mesoderm over here. So your innermost and your outermost layer fuse, that forms the umbilical cord. And then as a pregnancy progresses, the chorion and yolk sac decrease in size whilst the amnion increases. Okay, amniotic fluid. Then you don't have to know too much. Essentially, it functions to protect the fetus from a lot of things, whether it be physical trauma or temperature changes or compression of the umbilical cord. It allows some room for the fetus to move and grow. It's kind of gross because it's literally just fetal urine mostly, as well as some lung liquid, nasal secretions, skin cells. The quantity range starts off at around 10 mils at 8 weeks and ends up being like a whole liter. And it's really, really, really important. When there's too much, you call that polyhydramnios. And usually they'd have like serial amniocentesis. So they're taking fluid out of the amniotic cavity regularly if you have too much. And then oligohydramnios, when you have too little, oligo is what, too little. And they usually manage that by just delivering the baby because oligohydramnios also has a lot of other issues. You get like a flat face because you don't have enough amniotic fluid. The fetus has no space, so it's like squishing up against the mom's uterus. So they get a flat face. They get like peripheral issues. And they also have lung issues because lungs require amniotic fluid to develop by continuously breathing it in and stretching it. All right. Maternal adaptations to pregnancy. There are a lot. So the female body changes a lot during pregnancy. I've highlighted some of the more important ones. You do get weight gain, 4 kilos from the fetus, 2 from the fluid. You have 2 from the amniotic fluid, 1 from fat, 1 from birth. Basically what they were saying is you do get weight gain, but most of it is due to the pregnancy and you're not actually gaining fat. Energy costs is evenly split between the fetus, placenta, and mother. So she's going to be hungry. You get insulin resistance. So lots of, well, not lots, but like many women will get insulin resistance or gestational diabetes. You have a change in your hormones. You have an increase in cardiac output because you have to pump more blood around the body to get to the placenta and the baby. You have a decrease in total peripheral resistance. You have an increase in extracellular fluid due to the estrogen and aldosterone. You get a mild anemia. You have an increase in respiration rate due to an increase in progesterone, but also you have to obviously breathe out more and breathe in more because you need more energy. You have increase in renal flow, have increase in sodium retention. Sex determination. So in week 6 of gestation, the fetus is like, yeah, I'm gonna show you if I'm a boy or a girl. Males obviously have an extra Y chromosome, females have 2 X chromosomes. And this whole thing is dependent on this thing called the SRY gene. And that codes for TDF, or testes determining factor, on the Y chromosome. And it codes for the SRY protein, easy. In the males, it's present. And so when it's present, your bipotential gonads, what they mean by that is when you're like a fetus, an early fetus, you have gonads and they have 2 ways that they can go. They can turn into testes or they can turn into ovaries. So they're called bipotential. So the male has this gene so present, so they have their bipotential gonads will turn into testes, whereas in females, it's not present, so their bipotential gonads will turn into ovaries. And then because males have testes, they are able to form testosterone. And these are secreted by the Leydig cells and allows the Wolffian duct to form. In females, that's not present, so the Wolffian duct degenerates. And then testosterone can also turn into dihydrogen testosterone, and that causes the development of the male external genitalia. In females, that's not present, so you develop the female external genitalia. And then anti-Mullerian hormone is also secreted by the Sertoli cells, also in the testes. That causes the Mullerian duct, or like the female duct, to degenerate. Because AMH is not present in females, the Mullerian duct forms. And then by week 10, the testes descend, the cloaca forms, the penis, urethra, and the bladder. And in females, the Mullerian duct forms the fallopian tubes and the uterus. This is another summary for visual learners. I think Gavin went through a lot of this stuff yesterday, but essentially there are corresponding structures in female and male anatomy. Birth. Okay, preparing for birth. So before I said that the fetus was independent and dependent on some things. So before the fetus is born, it needs to mature areas that the placenta was functioning for. So the lungs need to develop surfactant. In the cardiovascular system, you have to close the AV shunts. The foramen ovale, the ductus arteriosus, has to develop and mature the gut. The kidneys generate its own heat for thermoregulation, and change the hemoglobin from fetal to adult type. And so how does this all happen? What is it triggered by? It's triggered by glucocorticoids. That's absolutely essential for the development of fetal organs and orchestrating the timing of birth. So you have this thing called the prepartum cortisol surge. So the whole time, kind of during pregnancy, you've got almost like suppression on your corticosteroids. But at the end, negative feedback mechanism is overrun. and that absolutely skyrockets. It's in the blue. Administration of corticosteroids before birth encourages the early development of the fetus, so it's more likely that the fetus will survive. And now we've done pre-birth, now we're going to give birth, so this is labor. You can split labor into like hormonal changes and physical changes. So the exact mechanism of the hormonal changes isn't really known, but you have a positive feedback loop with cortisol and placenta, and you also have an increase in DHEA via the fetal adrenal, which increases estrogen. They sort the hormones into two groups. So you have the uterotropins that prepares the myometrium for labor. So that causes that allows the myometrium to contract, and it also softens the cervix so that the child can pass. And that's essentially just your estrogen. I put decrease in progesterone because it's important, but obviously a decrease in a certain hormone isn't going to make it a uterotropin. So I'd say that's just estrogen. And it does all of these things to do that. And then you have uterotonins, and that causes the actual contractions. And that's oxytocin. And oxytocin is secreted from your posterior pituitary gland, unlike everything else, LH, FSH, which is from your anterior pituitary. It builds in the first two stages and falls, and that correlates with the Braxton-Hicks contractions, and it's involved in the Ferguson reflex. So the Ferguson reflex is basically the baby pushes down, that activates stretch receptors, moves up to your hypothalamus to send impulses to the posterior pituitary, and the posterior pituitary will release more oxytocin. And then prostaglandins, so PGF2 alpha and PGE2, they're both synthesized locally in the placenta in response to a rise in estrogen. So PGE2 can actually be administered to induce labor. That's it. So you have these 4 hormonal phases. Firstly, phase 0 or quiescent. You have the inhibitory effects of progesterone, prostacyclin, nitrous oxide. You have phase 1, activation, and that's towards the end of pregnancy, estrogen's stimulating these changes. So that's your uterotropins. And then phase 2, stimulation, the myometrium starts contracting under the actions of oxytocin and prostaglandins, uterotonins. And then phase 3, which is involution, and that happens after the birth of the baby. And you have a few sustained contractions to reduce the size of the uterus. These are the physical stages of labor. So you have stage 1, which are just regular painful contractions followed by relaxation. Again, you have dilation, shortening of the cervix, your uterine volume decreases, etc. Stage 2 is just delivery, and then stage 3 is the delivery of the placenta. Physical changes, like I mentioned before, you have your cervical ripening. That happens days to weeks preceding birth. Essentially it's just a loss in collagen tissue causes more compliance, allows the cervix to be more bendy so that the child can pass through. And then you have myometrial changes. So you have like short contractions, estrogen increases myometrial bulk, increases oxytocin receptors, and decrease in progesterone takes away the initial inhibitory effect of progesterone on myometrial activity. And oxytocin and prostaglandins increase myometrial activity as your uterotonins. Now your child's born, and your child needs to drink milk. So females need to lactate. You have stage 1 and stage 2 of lactogenesis. Essentially, stage 1 starts mid-pregnancy, and it finishes like early after childbirth, and that's only a little bit of stuff. secrete like small quantities of like casein and lactose, and you have colostrum about 2 days after birth, which is rich in protein and poor in lactose and fat. And usually lactation is inhibited by progesterone. So as progesterone slowly decreases, well, not slowly, but as progesterone quickly decreases, that inhibited lactation is taken away. So it triggers the onset. Stage 2 is secretion of copious milk. So as you can see here, there is a lot. And so there's actually transformation of the mammary epithelium so that there's more permeability, and there's also a change in secretion products as well. Suckling is this, and there are a couple things that you need to know about it. So there's like a positive feedback loop called the letdown reflex. Or maybe I'll come to that a bit later. But yeah, suckling increases prolactin by the anterior pituitary and oxytocin released by the posterior pituitary. And these two work on two different things. So prolactin will cause galactopoiesis, which is milk production. So just the formation of milk in the breast. Whereas oxytocin works on the letdown reflex, and that's for the milk to actually be ejected. So release of the milk. That's literally all you have to know about galactopoiesis. For the letdown reflex, it's actually a positive feedback loop. So the oxytocin acts on the myoepithelial cells, causing contraction, allows the milk to exit, and then receptors on the nipples, so the child drinks, and then the receptors on the nipples will send signals to your hypothalamus again, which will cause release of oxytocin by the posterior pituitary again. And breast milk provides all the basic nutritional requirements of a baby and maternal immunoglobulins for passive immunity. Lactational amenorrhea is literally just them referring to the period during, while breastfeeding where women won't menstruate. This wasn't my slide, but I think it's funny. That's all for today. Do we have any questions?
I will stop the recording.